Okay, sorry for my interruption of the lecture. Unfortunately, Dropbox could not withstand so much overload with the material, so I had to remove the lecture on intracellular accumulation, and we will continue our hemodynamic disorders from the point where we have stopped at Porto shunts. As I told you already, sorry. As I told you already, portocaval shunts, they are the consequence of shifting of the blood from the area with high pressure that occurs in case of portal hypertension in system of portal vein and its collaterals. The shift to systemic veins. And there are three main points where there is such formation of such collaterals. In the lower third of esophagus, where we can see formation of esophageal varices. Varices are dilated veins. The pressure dilates them. And usually rupture of these varices may be fatal because it is almost impossible to stop this bleeding. Next point is hemorrhoids, where there is collaterals between veins and the network of veins around the rectum. And caput medusa, it is a dilation of superficial veins on the anterior abdominal wall, where we can see fusion of veins from system of superior and inferior vena cava, as well as from branches of portal vein. And also there is a fourth anastomosis that is not of clinical use, retroperitoneal anastomosis, but we remember about them just in theory. And as I told you already, congestive splenomegaly, it's not a manifestation of portosystemic shunts, but very important manifestation of portal hypertension. So, where we can see these portocaval shunts around the rectum, around the lower third of esophagus, and on anterior abdominal wall and retroperitoneal anastomosis. So, on this photo, you see another important manifestations of portal hypertension: ascites, accumulation of fluid in peritoneal cavity. One of the portosystemic shunts that are visible on anterior abdominal wall got very picturesque name as caput medusa. If you remember Greek mythology, one woman had snakes instead of Medusa Gorgona had snakes instead of her hairs, and these snakes look similar with the dilated veins on anterior abdominal wall in patients with portal hypertension. That's why the condition got its name. And here you see esophageal varices, dilation of veins that became visible on endoscopic examination, and rupture of these varices may provoke fatal bleeding. Next type of hemodynamic disorder is hemorrhage. Hemorrhage, it is escape of blood from vessel or the heart. There are few types of hemorrhage. First one is hematoma. Hematoma, it is accumulation of blood within tissue with destruction of the tissue. And as a consequence, there is formation of cavity that filled with blood. And if you can imagine, if the patient will survive and this hematoma will be drained or reabsorbed, we will see formation of cavity instead of it. And when all the RBCs will be possessed by macrophages, this cavity will have brownish walls due to deposition of hemosiderin. If there is leakage of the blood in anatomical cavities, we can talk about hemathorax, hemopericardium, hemoperitoneum, and hemarthrosis. I hope that you can easily translate these terms Hemarthrosis, I should tell you, it is deposition of blood in the cavity of joint. Another variance of escape of blood inside of the tissues depends on its site and size. For example, petechia are very small, minute hemorrhages in the skin. Purpura, also small but a little bit larger, roundish hemorrhages in the skin and mucous membrane, more than 3 millimeters. Echymosis or bruises, larger hemorrhages approximately 1-2 centimeters in diameter. And hematomas are, as I told you already, a huge deposition of collection of blood in the tissues with their destruction. Also, you should remember terms that define escape of blood from different areas. For example, hematochezia, bright red blood per rectum. Melena, also, we have discussed it already. It is dark stool in patient with stomach bleeding. And last lecture, last class, we have discussed that interaction of RBCs with HCl in stomach results in formation of so-called hydrochloric hematine, the pigment of black color that gives dark color to stool and vomiting of patient with stomach bleeding. Hematuria, it is the blood in urine. Vice versa, in patients with chronic renal failure, we will discuss uremia, presence of urea. So not urea, of course, the waste products of protein breakdown in blood. Hemoptysis, coughing with blood. Hematemesis, vomiting with blood. Metrorrhagia, this term is used for uterine irregular bleeding. And vice versa, menorrhagia, it is abnormal, severe and prolonged menstrual bleeding that occurs in regular intervals. According to its etiology, hemorrhage may be due to rupture of vessel wall. In Latin, it is hemorrhagia per rexin. It may occur due to trauma, usually. Also, hemorrhage may be due to corrosion of vessel wall, or hemorrhagia per diabrosin in Latin. It occurs if there is inflammation, necrosis, or tumor growth inside of the vessel wall. And during our systemic pathology, we will discuss some examples that may provoke such bleeding. Also, hemorrhages may occur due to increased and severe increase, better to say, permeability of vessel wall when a lot of RBCs will be pushed out of the vessel. Of course, in this case, usually we deal with small minute hemorrhages like petechia or purpura, and usually it occurs if there is damage of endothelium due to some toxins, due to hypoxia or some allergic reactions. For example, here you see intracerebral hemorrhage in the form of hematoma. You see cavity that is filled with blood clot. Also here you see subarachnoid hemorrhage. You see basis of brain with deposition of blood clots. Of course, such hemorrhages are very dangerous as they involve vital organs and may be the death by itself. As well as hemopericardium, we can recognize lungs, and in pericardium there is blood clot that compresses heart from the periphery, causing cardiac tamponade. Outcomes of the hemorrhage, of course, they are different depending on site of the hemorrhage, because hemorrhage may be external as well as internal. If we are talking about escape of the blood in the tissues, it may result at first as a favorable outcome in reabsorption of blood, as I told you already, with formation of so-called rusty cyst. Rusty color, brownish color, is due to deposition of hemosiderin. Also, organization of hematoma and encapsulation due to formation of fibrous tissue as a normal response of injury may occur. Joining of secondary infection may result in suppuration of hematoma, and in this case we will see formation of pus inside of this cavity. And of course, loss of blood, severe loss of blood, will result in acute post-hemorrhagic anemia, and very severe loss of blood will lead to hypovolemic shock. So, shock. Next type of hemodynamic disorder. Shock or vascular collapse. It is a syndrome that is characterized by widespread hyperperfusion of tissues due to decrease of effective circulating volume of blood. There are three main pathophysiological types of shock. Why I'm telling you about three main types? Because we can classify shock according to etiology into traumatic, septic, spinal, as you like. But from pathophysiological point of view and from consequent treatment, the three most important types of shock exist. First one is cardiogenic shock. In this case, low cardiac output is the result of hypoxic and hypoperfusion of the tissues. It may occur if there is intrinsic damage of myocardium or compression of the heart from outside, or for example, if there is outflow of obstruction of the blood. And of course, in this case, as a doctor, you will have to try to stimulate, if possible, the heart to improve cardiac output. Next type of shock is hypovolemic shock. In this case, hyperperfusion of organs of tissues occurs as a consequence of reduction of circulating volume of blood or plasma, maybe due to severe hemorrhage or severe loss of fluid due to burns, due to persistent vomiting or diarrhea. Of course, in this case, there is no use to stimulate heart to pump more blood. In this case, you must restore the volume of circulating fluid. Next type of shock is septic shock that occurs in case of generalized microbial infection. Usually, gram-negative bacteria are responsible for septic shock because they may provoke endotoxic shock on their lysis. Gram-positive bacteria and fungi also may provoke septic shock due to presence of exotoxins. Also, in literature, you may find such types of shock as neurogenic shock if there is severe damage of spinal cord, and anaphylactic shock. Anaphylactic shock, to tell you the truth, in pathogenesis it is similar to septic shock in some way, because in this case there is widespread vasodilation with pulling of the blood to the periphery, with reduction of blood flow and hypoxia to vital organs. This occurs due to release of IgE with activation of IgE type 1 hypersensitivity. Few words about septic shock, how it happens, why vasodilation occurs. If there is a lysis of gram-negative bacteria in our organism, they may release endotoxins. Endotoxins are products of bacterial wall. They are lipopolysaccharides. They contain toxic fatty acid or lipid A core and complex of polysaccharide coat. Gram-positive bacteria and fungi, as I told you already, also may have some analogous bacteria. When lipopolysaccharides combine with lipopolysaccharide binding protein plus CD14 receptor on the surface of the monocytes or macrophages, this complex activates receptors on monocyte and send the message to the nuclei to overproduce, better to say, such cytokines as tumor necrosis factor, interleukin 1, interleukin 6, and interleukin 8. And these cytokines, they provoke systemic vasodilation and direct cytotoxicity. All this results in vasodilation with pooling of the blood to the periphery with hypoxia of vital organ. They diminish cardiac contractility. They provoke overwhelming endothelial injury. They provoke adhesion of leukocytes and activation of coagulative system. So you see that activation of this cascade has adverse effect on almost all organs in our body. And when we are discussing stages of shock, there are three of them. First one is non-progressive, when there is activation of compensatory mechanisms and organism try to maintain blood flow to vital organs, pulling the blood from periphery to the centrum. That's why um, peripheral parts of our body become hypoxic, but vital organs, they still get proper circulation. Also, at this stage, there is release of catecholamines to maintain blood pressure, and kidneys try to reabsorb more fluid to maintain circulatory volume. And what is very important, that in non-progressive stage, there is no metabolic acidosis as organism tries to compensate this hyperperfusion. In progressive stage of shock, tissue anoxia, it progresses, and anaerobic glycolysis results in metabolic acidosis. Because metabolic acidosis, it worsens vasodilation and hyperperfusion that also start to affect vital organs. And in irreversible stage, there is progressive and uncontrolled vasodilation with severe tissue anoxia, with severe damage of endothelium. And in this stage, we understand that nobody can help our patient because he or she will die due to failure of multiple organs that catching one to another will form a vicious cycle. To discuss morphology of shock, it is just necessary to summarize manifestations of acute left-sided and right-sided heart failure. So, with small additions. So, in lungs, at first, as a manifestation of acute left-sided heart failure, your patient will develop pulmonary edema, but later, transudate that you saw in alveoli that contains more fluid and less proteins will aggregate, will polymerize, and finally we will see formation of dense pinkish material that we will name as hyaline membranes, and these hyaline membranes are responsible for acute adult respiratory distress syndrome with formation of respiratory insufficiency. In liver, as a manifestation of acute right-sided heart failure, we will see central lobular necrosis that we have mentioned already. Of course, it will worsen liver function. It will provoke a decrease of abilities to detoxicate blood. So also it will play a role in formation of vicious circle. The same happens with kidneys as acute tubular necrosis occur in this organ, also as a consequence of acute right-sided heart failure. In GIT, we will see formation at first of numerous minor defects on mucous membranes as a consequence of hypoxic damage of mucous membrane. And these defects will be the source for bleeding. That's why bleeding from GIT, from stomach, from intestine is a very common manifestation, but to say complication of any shock. In myocardial infarction, in myocardium, we will see formation of small necrosis in subendocardial areas, in the areas that are the most remote from the coronary arteries. And of course, loss of alive cardiomyocytes will worsen cardiac function, progressing hyperperfusion. Here's what I told you already. Necrosis of epithelium of tubular canal. If you remember, necrotic cells, they look like homogeneous eosinophilic masses in any organ, and on cut surface you can see so-called shock kidney with bright border between pale cortex and dark red medulla due to redistribution of blood. And then liver, you saw the picture already. Central lobular necrosis around central vein hepatocytes are dead. They also look like structureless masses, imbibited with RBCs due to hemorrhages. And here you see gastrointestinal tract with numerous reddish defects on the mucous membrane. These defects are erosions, and bleeding from them sometimes may be fatal. In brain again we can see edema. It's a manifestation of acute right-sided heart failure and so-called brain ischemic encephalopathy when we see lack of neurons, when we see loss of um, dendrites, neurons, axons, and so on and so on. So, as I had to interrupt my lecture earlier there that I have planned, I will deliver another one pathological process, and we will have only two types of processes, embolism and disseminated intravascular coagulation, left for the third part of the lecture. So thrombosis, it is formation of solid mass from constituents of blood within cardiovascular system during the life. This mass may be formed in blood vessels or chambers of the heart. And to discuss pathogenesis of thrombosis, it is necessary to discuss Virchow's triad. If you remember Rudolf Virchow, whom I introduced to you during the first lecture, the father of modern pathology, and during our course we will face many times with some pathological conditions named after him. So, Virchow's triad, it includes endothelial injury, stasis or turbulence of blood flow, and blood hypercoagulability. What may provoke endothelial injury, and that's why what may provoke and be the risk factor for thrombosis. Of course, it is tissue damage, as normally where we can see formation of thrombi. Also, atherosclerosis, if you remember from our lecture number 2, atherosclerosis, it is a disease that is characterized by deposition of cholesterol, and obesity as its risk factor also damages endothelium due to deposition of cholesterol and lipoproteins. Hypertension affects endothelium due to physical damage. And toxic products, like in case of smoking, absorption of them in blood provokes damage of endothelium. Next point, in Virchow's triad, abnormal blood flow. Two types of abnormal blood flow we should mention here. Turbulence of blood flow and stasis, slowing down of blood flow. Both of them may predispose to thrombus formation. Turbulence of blood flow, not laminar blood flow, may occur if there is some kind of bulging of heart or vessels, like in case of aneurysms, or when there is abnormal chaotic heartbeat. In this case, turbulence will occur in the chambers of heart. For example, in case of the different arrhythmias, and more dangerous in this point of view is atrial fibrillation. Or if there is, for example, varicose veins in some location, or valvular defects of the heart. Stasis, slowing down of blood flow. If there is slowing down of blood flow, the chances of the cells to get stick to one to another increases. And that's why, for example, we know that in immobile patients after surgery or fracture, the risk for venous thrombosis in lower extremities increases significantly. Also, for example, in patients who have hyperviscosity of the blood, for example, in case of pregnancy, or patients who has sickle cell anemia or some malignancies of blood with uh, increased hematocrit, they also have slowing down of blood flow, and that's why tendency for thrombosis. Also, hypercoagulability. It is misbalance in pro and anticoagulation system that may predispose for thrombosis. There is a vast majority, there is a lot of primary or genetic disorders when there is mutation in the gene coding pro-thrombogenic or anti-thrombogenic proteins, and also hypercoagulability may be acquired. For example, the best example is disseminated intravascular coagulation that covers all the conditions with release of tissue thromboplastin, for example, after damage of the tissues due to surgery, fracture, or if there is decay in cancer with formation of paraneoplastic syndrome. So let's talk about types of the thrombi. They may be non-occlusive if it does not cause obstruction of the vessel, or they may be occlusive. Of course, in case of non-occlusive thrombi, we will deal just with diminution of blood flow, and the affected part that gets blood flow through this vessel will suffer from hypoxia. In case of occlusive thrombi, we will talk about ischemia, and in this case, the affected part will have absolute decrease of blood flow. According to localization and cardiovascular system, thrombi may be arterial, cardiac, venous, or capillary, and all of them will have different effect. For example, on this photo, you see coronary artery. Here, I should tell you there is atheromatous plaque. So there is atherosclerosis, and plaque is disrupted. You see rupture of the superficial areas of the plaque where thrombus superimposed. So that's why atherosclerosis with damage of endothelium, it is one of the risk factors for thrombosis. According to gross appearance, thrombi may be white, red, and mixed. White thrombi, they are predominantly composed of platelets and white blood cells, and usually they develop in the vessels, usually arteries, where blood flow is rapid. Red thrombi, they start from minor aggregation of platelets, and then a lot of fibrin and RBCs become trapped in this thrombus. Of course, due to slow growth of these thrombi, they usually develop in vein where blood flow is slow. And mixed thrombi, they have alternating layers of white and red thrombi that are called lines of Zahn. And in these usually mixed thrombi, they are huge. And in mixed thrombi, we can recognize so-called head, the part of the thrombus that is attached to the surface, to the internal surface of the vessel, body, and tail. Tail that freely moves in the lumen of the vessel, and if head has a composition of white thrombus, tail usually had composition of red thrombus. Of course, such huge thrombi we can see usually in large arteries like aorta, especially if there are aneurysms of aorta. Here you see typical mixed thrombi with lines of Zahn, and here's how thrombus look like under the microscope again. Arterial thrombi. Usually these thrombi are occlusive. They develop due to rapid blood flow They are most dangerous and most commonly localized, causing clinical effects in coronary, cerebral, and femoral arteries. Usually, they are consequence of superimposing of fibrin RBCs and platelets on atherosclerotic plaques, and usually they are gray, white, and friable, contain, as I told you already, of platelets, fibrin, RBCs, and degenerated white blood cells. They grow in retrograde direction, starting from the point of their attachment. For example, here you see wall of coronary artery that is occluded totally by thrombus, predominantly formed by fibrin. Venous thrombi, they usually occlusive red thrombi, usually develop in vessels where there is very slow blood flow, low pressure, vessels that may be very easily compressed from outside, and usually in veins where there is varicose dilation, where there is formation of spirals around veins valves, and these thrombi may propagate, grow in extent to the heart. So they will grow from distal part, for example, of lower extremities to proximal part. And in literature and in practice, there were such cases when, for example, thrombus from popliteal vein grew through femoral vein through inferior vena cava to right chamber of the heart. Can you imagine how huge it could be? If there is inflammation of the thrombus that is fixed to the vein, this condition we will name is thrombophlebitis. If thrombus is formed in unaffected vein, this condition is called as phlebothrombosis. To tell you the truth, due to superimposing of inflammation, of course, thrombophlebitis has brighter clinical picture as compared to phlebothrombosis. Predominantly, I should say, uh, veins of lower extremities are affected. Here, for example, you see some artery occluded with thrombi. Here you see huge thrombus, most probably in the vein, and capillary thrombi, minor thrombi that are made up of red blood cells. Here, for example, in the loops of glomerulus. And usually the consequence of damage of capillaries by inflammatory process or vasculitis, or they may be the hallmark of disseminated intravascular coagulation. Cardiac thrombi. These thrombi arise in heart chambers. Of course, usually they are non-occlusive because it is very difficult to image so huge thrombus that may overline, that may fill all the cavity of the heart. The most common reason for mural thrombi is arrhythmias. Arrhythmias is abnormal contraction of the heart causing turbulence of blood flow inside of it. Or if, for example, there is transmural through all the layers of the heart, myocardial infarction, with damage of endothelium, endocardium, and superimposing of the thrombus. If there is superimposing of bacterial or fungal infection on the cusps, in this case we can see formation of huge thrombotic masses or vegetation. These vegetations we are discussing in the case of bacterial endocarditis. In some cases, we can see sterile vegetations in patients who has hypercoagulability state, uh, for example, in some autoimmune diseases like systemic lupus erythematosus. Let's have a look. For example, here in the chamber on endocardium, there is superimposing of the thrombi. Here the thrombus locate in a left atrium. If such thrombus will detach, of course it will pass at first to left atrium and then through aorta it will affect any of its branches. And here what we can see, it is a huge aneurysm of aorta that is filled with thrombus. If we will look at venous and arterial thrombi, risk factors are different. Pathogenesis in arterial thrombi predominantly associated with turbulent blood flow and damaged endothelium. In veins, stasis and hypercoagulability predispose for it. For arterial thrombi, onset is sudden. For venous thrombi, it is usually slow. And the main complication that occur due to arterial thrombi is infarction of different organ or ischemic necrosis due to interruption of blood flow, and arterial embolism when, for example, the specimen of thrombus from the larger vessel may detach and flow in the direction of blood flow, occluding smaller vessel. For venous thrombi, the main complication is pulmonary embolism, when the thrombus will detach from the vein and through system of inferior vena cava, usually it will pass to right chambers of the heart and then to pulmonary artery. Outcomes of thrombi. First one is unfavorable and it is propagation. Enlargement of the thrombus inside with deposition of more and more constituents. Of course, in veins, thrombus will flow or will grow towards the heart, in arteries vice versa, in the direction from the heart. Embolization, it is detachment of the piece of the thrombus with transport of it in the direction of blood flow. Dissolution or resolution, it is favorable outcome. It is a removing of the thrombus by our organism through activation of fibrinolytic system. Organization, it is replacement of thrombus by connective tissue. Also, this outcome is not very good because it will not restore blood flow and the affected part will suffer from ischemia or venous hyperemia. And recanalization, when there is ingrowth of capillaries from the endothelium inside of the thrombi that will restore blood flow through it. Let's have a look how it will happen. No resolution, just diminution of the thrombus, embolization. In this case, they suspect that the thrombus from vein was detached and passed to branch of pulmonary artery. Organization, when there is fixation of the thrombus due to formation of fibrous tissue and it became the piece of the vessel. And recanalization with formation of small capillaries inside of the thrombus and restoration, partial restoration of course, of blood flow. Propagation toward heart, for example, from popliteal vein, thrombus may grow to femoral vein and inferior vena cava. Here you see, for example, organization, ingrowth of fibrous tissue to the lumen, and in the centrum you see formation of newly formed vessels. Now I think we will not discuss how we will differentiate post-mortem clots from real thrombi. And complication of thrombi. If there is interruption of blood flow, arterial blood flow by thrombus, it will provoke ischemia, decrease of lumen by thrombus, narrowing of the lumen by thrombus, if there is not total occlusion, will provoke hypoxia with diminution of blood flow. Ischemia, of course, will be the reason for infarction. And the main complication of thrombus, especially venous, is also thromboembolism. And about embolism, I think we'll talk in the third part of our lecture. So I think we have finished with it, and wait for part 3.